Assalamu alaikum. It's my great pleasure to introduce the speaker of the grand round today, my colleague and friend, Dr. Ajmal Ahmad. Dr. Ajmal Ahmad is an assistant professor in the Department of Ophthalmology, College of Medicine, King Saud University. He had a PhD degree in basic science research and also postdoctoral fellowship from two universities in the United States. Dr. Ajmal Ahmad, he is a member of the research team of Dr. Nasser Rashid Research Chair in ophthalmology. Today he will discuss the role of inflammation in the pathogenesis of proliferative diabetic retinopathy. As you know, nowadays there is strong belief that there is a strong mechanistic link between inflammation and angiogenesis in cancer, and also we showed this in diabetic retinopathy. So he will discuss today, according to his title, the involvement of interleukin 11, interleukin 11 receptor alpha signaling in the initiation and the progression of proliferative diabetic retinopathy. Dr. Ajmal.
Yes. Hello, everyone. And first, I would like to thank Professor Abu Assar for that kind introduction. So thank you very much. So today I'm going to discuss about the inflammation, the role of inflammation in the initiation and progress of proliferative diabetic retinopathy. So now the first question comes in the mind that what is inflammation? Very basic concept. We need to understand what is inflammation. Inflammation is actually the response of vascular tissue, the response of vascular connective tissue against injury. What does it mean? It means that if there is any significant injury, then there will be the inflammation, and there will be the inflammatory response, and there will be the inflammation activation of inflammatory cells. Why this concept is very important? Because we know that because the doctor deal every day with the inflammation. Every day they're dealing with the inflammation if there is an injury. Because inflammation is a mechanistic procedure, step by step, if we can understand, then we can say it is a vascular problem. It is the problem of vascular system. And that vascular system is the problem of vascular connective tissue. So we will see that in PDR, there is a damage of vascular connective tissues. Because in our body, if you can see in our body, there is no cell which is not vascularized. Almost all cells are vascularized, almost all cells. So we can say that every cell is connected with the vascular system, every cell. And why I'm talking about the connective tissues? Because blood is also one of the connective tissues. And we know that connective tissue play a major role in all over the body, including in the disease progression in PDR, proliferative diabetic retinopathy. And if you can see that actually connective tissues, why they are very important? Because in this PDR, we will see that there is a role of endothelial cells. Endothelial cells are also connective tissue. It's a role of fibroblast. It is also a connective tissue. It means that all the connective tissue is actually derived from the mesenchymal cell. Mesenchymal cell. During the embryonic stage, some connective tissue, actually the definition of connective tissue is cells plus extracellular matrix. So connective tissues is the most important part because it communicates between each other. We know that the lining of endothelial cell, the capillary lining, the basement membrane, and after that extracellular matrix, and all the connective tissue cells like fibroblasts, like macrophages, because they are all derived from the mesenchymal stem cell. Some connective tissues are permanently resident inside the tissue area, inside the interstitial tissue, and some are coming through the blood, because blood is also the connective tissue. The overall purpose of discussing this thing is what? The overall purpose to discuss that the disease what I'm talking about, the inflammation, it starts from the vascular problem, vascular compartment. And this vascular compartment leads to the problem to the interstitial tissues, interstitial tissue. So it means that proliferative diabetic retinopathy, if we understand the retinopathy, that this problem is the vascular problem. And this vascular problem is changed into the tissue injury. So there is a very cross link between the angiogenesis problem, and when there is a damage to the tissue, then inflammation. It means that PDR is associated with the connection of vascular problem as well as interstitial problem. It is a cross link between the angiogenesis and inflammation. Inflammation. So before going to discuss about this, the interleukin role, this we know that what is an interleukin? These are the cytokines, and you know the cytokines. Everybody knows there are cytokines. Cytokines are they are the chemical messenger. These chemical messenger are released by the connective tissues, released by the macrophages, released by the endothelial cell. And you know, this chemical messenger actually modulate the function of the other tissue, this chemical messenger. So that's why interleukin means it is the communication between the two leukocytes which previously no people. That only two leukocytes, they send one message from the second cells between the leukocyte, but now there is, we know that these cytokines, they are acting as a paracrine. It means that they target to the neighbor cell, modulate to the neighbor cell. Even autocrine, it binds itself, modulates its own function. Even endocrine, they target to the distant tissue. So that's why this one molecule interleukin 11, which is a proteinaceous, very short-lived, but its function is huge. This interlocks cytokine, the chemical messenger, which transfer one message to another. And what are the message? They are chemical messenger. When there's a tissue injury, they are going to call all the immune cells, neutrophils, macrophages, and these are coming through by the interleukin 11, by the cytokines, by the cytokines. So now what is diabetic retinopathy? Very important to understand that retinopathy. Pathy means disease, retina. It's a disease of the retina. Actually, overall the period of time, we can say one of the very important consequences of the diabetes is retinopathy. If your diabetes is very long, more than 10 years, then that patient is having suffering with the diabetes. And that patient, diabetic patient, in fact, it is the problem of the microvascular complication. That is a microvascular complication. So that's why, because of microvascular complication, there is a disease in the retina. As we know that there is a supply of blood supply, ocular blood supply to the retina and the vitreous chamber. There is a two type of supply: central retinal artery and choroidal retinal artery. So why the diabetic patient is a problem of microvascular. And that's why we can see that if the diabetic patient, more than 25% are common in diabetic patient, that is going to lose its vision. It's a visual problem. It leads to blindness. It's a disaster. It is very terrific. Means we can say that it's a very dangerous situation if diabetic lasts more than 10 years and it's become more chronic, then it become more problematic to the eye, to the retina. And it's very difficult to treat the retina. That's why if inflammation, you can see it is divided into the two parts, acute and chronic. Acute is a very short-lived, you can deal with this inflammation, but when it becomes the chronic, that will lead to the diabetic retinopathy. So retina problem, in the retina, there's a disease because of diabetes, because the occurrence of diabetes, that is called diabetic retinopathy. This occurred due to the diabetes mellitus. It means that this is the vascular problem, capillaries problem. These capillaries are going to be very leaky and they are very sharp, and it become injured. And after that, it leads to the injury of the retina. That is called diabetic retinopathy. So we can say that it is the visual problem. It is a problem in looking, eye vision problem in the working age population. If the diabetes is more than 60 years, or we can say if the diabetes lost from more than 20 years. And you know that the diabetes is actually because of high glucose, hyperglycemia. Whenever the diabetic patient, the glucose level is high, then there is a problem in the pathology in the retina. And that's why we can tell that this is the hyperglycemic mediated pathologic alteration in the retina of diabetic patients. Initially, you cannot see that there is a problem in the retina. This is the very problem that we cannot diagnose initially because it is asymptomatic. It gradually, it grow gradually. The problem develop gradually. The progression develop gradually, and in the advanced stage, that is in up to the proliferative diabetic retinopathy. Proliferation diabetic retinopathy. New vessels are developed. New vessels. What is the new vessels? That is new capillaries develop, new growth develop, and that growth is unbridled, uncontrolled. You can say that the developer and new vessels are going to develop inside your retina. That is proliferative diabetic retinopathy. That's why the patient of PDR. Here I want to say that patient of PDR is characterized by the new vessel formation, growth of new vessel formation because of vitreous or perineal hemorrhages. That's why we can say that. So actually the retina, if you see the structure of the retina, there's a vitreous cavity. You know that there's a fluid, two type of fluid in the eye present. That is the vitreous and the humor, aqueous humor, aqueous and vitreous. In fact, vitreous, what is the role of vitreous? The role of vitreous is that to distend the proper position of retina, that it maintain the ocular clarity, it maintain the ocular structure, the role of vitreous. And once the problem occur in the vitreous, of course it is going to change in the pressure. That's why if the pressure is changed, then the ocular function and that the molecular structure of the vitreous, that is going to lead with the problem, the metabolic or problem in the retina. So basically, if you can see that uh, talking about the retina and the vitreous is present between the retina and the lens. So the vitreous is the very important for the ocular clarity, very important to maintain the visual side. It should be a ocular structure should be intact. It provides. This is the very important function of vitreous. In fact, you can say the vitreous. What is the vitreous? Vitreous is the very gel and gelatin-like structure. It is a gel filled with the gel. And you know, it having the very thin fibrils with the proteoglycans, elongated proteoglycans. This is the vitreous, what we can say. And this alteration and this is a problem in the vitreous. Suppose there is a problem in the vitreous, of course, there is a surface between the retina and the vitreous surface. Then this becomes the pathological vitreous alteration take place at the interface between the vitreo and retina. And all these events occur because of change in hypoxia, oxidative, inflammatory, neurodegenerative, and leukostatic condition that occur during diabetes. Because you know the diabetic condition, there is a problem in the hypoxia. It leads to the hypoxia. It leads to the shear stress chain. Then after inflammation, and the inflammatory is going to produce more of oxidative stress. Then there is the degeneration of your rhodopsin, neuronal layer of the retina, and after that, your everything become inflamed because of these events, because of diabetes. There is a change of all these things that is lead to the pathology in the retina. Classically speaking, if I can talk about the stages of diabetic retinopathy, because after that, when I'm going to deal with the paper that cytokine is involved in the initiation and the progression of diabetic retinopathy, you will find that there are non-proliferative diabetic retinopathy and there are proliferative diabetic retinopathy. So let us understand in a very clear way, because that's why when I will go through the letter, then you can understand much better. So non-proliferative diabetic retinopathy. Once is here, one thing is very clear. In non-proliferative diabetic retinopathy, there is no new endothelial cell, but the supply, the ocular blood supply, you can see the microaneurysm, that the blood vessel swelling, and after it swells, you know that there's a hemorrhages. It will break down, and the content of the blood vessels. For example, you know plasma proteins are there, antibodies are there, complement proteins are there. Immune cells are there, macrophages, neutrophils, all now these are now going to escape from the vascular compartment to the interstitial compartment. That's why the third point is vascular permeability is increased. And you know the vascular permeability when increase, these all proteins are called exudates, and there's an exudation of this protein, exudates, extravasation. Now your all these components of the blood vessels in now you can see in the vitreous, the pool of the vitreous in non-proliferative diabetic retinopathy. And as non-proliferative it progress, it means that it will change into the proliferative diabetic retinopathy, because if the retina is damaged for a long time, it will lead to the hypoxic condition. The tissue undergo ischemia. And you know, for the tissue, for the retina, it needs supply of oxygen and nutrient. Once this tissue undergo hypoxia, now it needs neovascularization. It needs neovascularization. Means supply of new blood vessels. But unfortunately, this supply of blood vessel is immature, very weak. There is no tight junction between the endothelial cell. These endothelial gaps are very much. And because of these endothelial are so weak, that instead of helping, now it is going to rupture, and now it leads to vitreous hemorrhages. All the contents are going to, blood vessel will be ruptured, and all the permeability will increase, and it will go into inside the vitreous. That's why, and the tissue become inflamed retinal tissue. That's why we say that proliferative diabetic retinopathy is the crosstalk between the angiogenesis and inflammation. It means that it is so easy to understand that retinopathy, because of diabetes, it is a retinopathy. Okay, that's fine. Because of there's a problem in the vascular system, problem in the capillaries, problem in the blood vessels, it will be the microaneurysm, microhemorrhages, vascular permeability, and hard exudate. That's fine. And that NPDR, if advanced stage, there's a continuous damage to the retina that will lead to the tissue ischemia, and after the neovascularization, vitreous hemorrhages, and now it is the problem with between the angiogenesis and the inflammation. So to understand more clear, PDR, proliferative diabetic retinopathy, here you can see that this is the new angiogenesis, neovascularization. This blood capillaries, you can see this blood capillary, it is the leakage causes cloudy of vision. It is leakage. Once it leakage increase in the vitreous chamber, this jelly-like substance, this is the gelatin substance, it leaks, it will change in the pressure. As much this, and this is called the cloudy of vision. And we know that there is a macula is present just near the retina, which is responsible for the short vision. And this because the content is coming outside, the fluid from the vascular compartment to come into the interstitial tissue, to come into the vitreous chamber, it causes macula to swell and blurred vision. It causes macula to swell and blurred vision. That's why retina damage, and when retina, the portion of the retina is pull out, it leaves its original place, and because there is a wound healing start, there is a scar tissue formation take place. As we know that when there is wound healing, a lot of collagen is released, and because it becomes fibrotic tissue, and when it shrinks for the wound healing, when it shrinks, then there is a retinal detachment, and eventually that leads to the blindness. So this is the pathophysiology of proliferative diabetic retinopathy. Now this, why I'm showing this video, because actually you can understand about what I'm going to talk about the vitreous bodies, and after that I will talk about the retina substance. And you know the retina, in between the retina and the vitreous there are multiple cells, but the most important cells, because I will talk about the Muller cells, which are one of the glial cells, and other cells we know that there is a, a retinal epithelial cells, and after that you know the rhodopsin, rods and cones are present, and ganglionic cells, and then after that you can see the horizontal cells, amacrine cells, interplexus cells, and Muller cells, amacrine, and microglial cells. Because this figure is very important, because I am going to talk about the Muller cell, which is a very important cell. It keeps the retina framework properly, and also that Muller cells are the sources of cytokines. They release a lot of cytokines. Massive amount of cytokines is released by the Muller cells. Muller cells. Now coming to the rationale of our study, that talking about the interleukin 11 and its receptor signaling initiation and progression of the proliferative diabetic retinopathy. As I discussed about the PDR is the most advanced stage, and there's a neovascularization, inflammation, and fibrosis are critical mechanism for for proliferative diabetic retinopathy development and progression. I know what are the fibrotic because the scar tissue is development due to the inflammation, and because these blood vessels leaked out, and this caused retinal detachment. So it means that I'm talking about the during the PDR patient, you will see the outgrowth of fibrous epiretinal membrane at the vitreoretinal interface, which is the hallmark of the PDR. What does it mean? It means that at the vitreous and retinal surface, there is outgrowth of retina, outgrowth. This membrane is actually the hallmark of PDR. And this membrane actually is contributing the retinal detachment. Just I explained before how retinal detachment take place, and that is called loss due to the vitreous hemorrhages. And so interleukin 11, these cytokines, this chemical messenger, actually having the very important role. These are pro-inflammatory, pro-angiogenic, and it is involved in the cancer of epithelial cell. It enhances angiogenesis process. It activate inflammatory cells. It means it is the inflammatory, very strong inflammatory molecule. It will increase the inflammation. And the second thing, what I want to say about the macrophages, because inflammation, the cascade, we know that inflammation initially, inflammation is the vascular problem, vascular connective tissue. So macrophage is there, macrophage. We know that when it is in the circulation, it is monocytes. But when it comes to the interstitial tissue, when the tissue is injured, when the tissue is injured, it needs to remove all the necrotic cells. Dead cells, they have to need to the role of the macrophage to remove the necrotic and dead cell. So we will see that these cytokines are pro-inflammatory and pro-angiogenic, and during this inflammatory disease, there is the activation of macrophages, M2 macrophages. And we know that macrophages are the scavenger receptor, that it removes the dead particles, it removes the necrotic death which is occurring at the tissue level. So this is the role of macrophage. Macrophages are the big eater. First of all, actually, when there's an injury, this is the very principle about the inflammation. When there's an injury, neutrophils comes. The question is that why neutrophils comes? Because the number of neutrophils is more, it is always in the surveillance, but neutrophils is followed by the macrophages. Then it releases the chemotactic factor and bring its friend macrophage to deal with the injury. Then macrophage comes, and this macrophage is going to be the big eater, phagocytized in nature, and is going to eat all those dead tissues and necrotic tissues. This is very important for the macrophage having two phenotypes. It is a polarized M1 and M2. Nowadays, scientists is just very interesting about the M2 macrophage, that how it changed from M1 to M2, because M1 property is different, M2 property is different. M1, this is activated by the microbiome and the interferon gamma. And this M1 is actually antimicrobial, anti-tumor, and anti-angiogenic. Opposite to that, in contrast, M2 is activated by the interleukin 4, 10, and 13. And it is anti-inflammatory. It is pro-tumoral, but M1 is anti-tumoral. M1 is anti-angiogenic, but M2 is pro-angiogenic. And the ADAM17 is the disintegrating metroproteinase, which cleaves the CD163, which released in the media, that is soluble CD163, and that is a specific marker of the macrophage, M2 macrophage. This is specific marker of the M2 macrophage. So overall hypothesis is that M2 macrophage and this cytokine, they are going to play a very important role in the inflammation, involved in the angiogenesis pathway, implicated in the pathophysiology of proliferative diabetic retinopathy. How? We will see. So we investigated. So there's a problem. We will investigate that there is a membrane, epiretinal fibrous membrane from the PDR patient. We take the PDR patient, and then we investigated the M2 chloride macrophage and the expression of these cytokines and its receptor, interleukin 11, which are pro-angiogenic, and they are playing the angiogenic activity. The first portion is that apart from this, so we know that I already discussed about the membrane problem, the retinal detachment, and the vitreous problem. So all over the in the fluid, all the content, that is all the cytokines, all the plasma protein, complement protein, and all the leukocytes, everything is coming inside the vitreous. So first of all, we will see the marker of macrophage CD163 and the cytokine interleukin 11 and its receptor where epiretinal fibroscope membrane, patient of PDR. And we will see in the vitreous also that, of course, in the vitreous, this cytokine is present or not in the patient of PDR. Then we will correlate with the angiogenic factor, that is the VGF. And after that, I have shown you the structure of the Muller cell. You know, the Muller cell having a lot of function. This Muller cell having the two processes. One process is toward the retina and one process toward the vitreous, that is providing the foot providing the framework, and it produces a lot of cytokine playing the major role. So we mimic the condition. We use human retinal Muller glial cell in the cell culture, and we treat with the TNF alpha, hypoxic carbochloride, and hydrogen peroxide. And after that, we see that there is expression increased cytokines, alpha, interleukin 11, or not. We will see. So these are our discussion is actually based upon the human vitreous fluid and the epiretinal membrane. And after that, human retinal Muller cell, that is a cell culture. And the results are here. Results are very interesting. Why it is very interesting? Because you can see here, first of all, I will discuss that if you're going to deal with the fibrovascular membrane, this is the immunohistochemistry figure. The first figure A represents that. Here I am going to show you the expression of CD31, which is the marker of endothelial cell, leukocyte marker of CD45, and of course myofibroblast. We know that this fibroblast will become angry, change into myofibroblast, lot of collagen for the wound healing. So here we can see that in the first figure A, there is a negative control. It means that omission of primary or secondary antibody. Second is involvated PDR. What do you mean by involvated? This inactive PDR, you can say only fibrous tissues are present. Well, fibrous tissue, it means that here the blood vessels are very few. But in the active PDR, as I discussed, this pathology of active PDR, because of tissue hypoxic condition, there is a growth of new blood vessels. Lot of blood vessels you can see here in CD31. And expression of CD31 is huge, massive. Its level is increased in the active PDR. And stromal cells, that is leukocytes, there's increase in the CD45. Actually, you know, two type of cells are present. Sometimes people confuse the stromal cells. In fact, two type of tissue is present: parenchymal tissue and stromal tissue. Parenchymal tissue, the real tissue, that is neuronal tissue, if it is hepatocyte, hepatic tissue. But stromal tissues are the connective tissues. And the connective tissues, they may be leukocyte, they may be a fibroblast, they may be osteoclast, they may be a macrophages. These are the stromal cells, connective tissue. So here you can see the level of CD45. Here the level of CD45 leukocytes, its level increased. More leukocytes are present. And what are leukocytes? Are white blood cells. Leukocyte means white blood cells. And these white blood cells are, you know, granulocytes and agranulocytes. So agranulocytes are the macrophages and lymphocytes. And the granule, where the granule is present, that are neutrophil, eosinophil, and basophil. But here the leukocyte white blood cell, and this is the marker of CD45. Even you can see more expression of alpha smooth muscle actin. This is the marker of myofibroblast. So this figure represents that in the patient with PDR, you can see the epiretinal fibroscope membrane. In active PDR, there is a more endothelial cell, there is a more leukocyte infiltration, there is a more expression of alpha smooth actin, muscle actin. It means that now entire the conclusion that inflammation is going on, because these are the inflammatory molecules, vascular connective tissue, they are increasing the number in the PDR patient. Now this slide represents that expression of CD163, expression of CD163. In fact, this expression, you can see that endothelial cell is also a marker of CD163. Here you can see that there's a expression of, this is the PDR patient. I'm talking about the PDR patient, EP retinal fibroscopy membrane. The expression of CD163 is also marker of endothelial cell. Even spindle shape, you can see stromal cells. These are the connective tissues. There is the presence of CD163, and the C slide tells that macrophages are there because there is a double immunohistochemistry, which is showing that there is a CD68 is present and CD163, that is a co-expression with the macrophage marker and co-expression with the stromal cells. Now we discussed about the CD163. Now interleukin 11, this cytokine, focusing on this cytokine. This is very dangerous molecule. This is very nasty molecule. When its level is high in the PDR, that leads to a very disaster condition, we can say. So in this epiretinal fibrosarcoma, we have seen that in the vascular endothelium, in the stromal cell, there is expression of ligand into interleukin 11. In involuted PDR, endothelial cell, there is a very less receptor is present, but in active PDR, you can see this receptor is huge. It means the expression level is increased, which is pasted on the endothelial cell. It is where it is plastered on the endothelial cell. Its expression is huge, you can see here in the endothelial cell. Receptor is more. It means that ligand will bind and it will increase. The more inflammatory cells will come and more inflammation, the booster of the inflammation will increase. And here you can say in the PDR, involuted PDR, there's a less leukocyte, but when the condition is PDR advanced stage, then you can say there is the leukocyte expression is very high, with this receptor is also very high in active PDR. Now here we can see very most important, as we know that retinal detachment is actually linked with the fibroblast. You know, when the collagen is more myofibroblast, it is a wound repairing process. It actually doing the wound repairing process is the only problem, the retinal detachment, proliferative vitreoretinopathy. So you can see here that in the proliferative vitreoretinopathy, PVR is actually different from the PDR. It is PVR is actually complication of rheumatogenious retinal detachment. Rheumatogenious also disease, but this is the different. It is not related to the PDR. It is a rheumatogenious retinal detachment. In this also, in this PVR sample, patient with this epiretinal fibrocellular membrane, which is likely to be more fibrotic, you can see alpha smooth muscle actin, expression of CD163 also there. Even this ligand is also there in PVR. In this CD163 with macrophage CD68 also present there in myofibroblast. The expression in the epiretinal membrane is increased in myofibroblast. This is the comparison between the, we can see the expression of the stromal cells of epiretinal fibroscopy membrane in the angiogenic activity of PDR. So here we can see that blood vessels expressing CD31 in the active PDR is more as compared to inactive PDR. Even the CD163 also is expressed, and it's also more active in PDR. It is increased because the situation of active PDR is, you know, it's very different from the inactive PDR, because there's a new vascularization, more new cells are formed, new vessels, capillaries are going unbridled, uncontrolled. Stromal cells also express the CD163, as I told about the connective tissues, and blood vessels also expression of interleukin 11 is high, increased as compared to the inactive PDR. Even the vessels grow expressing also more as compared to inactive PDR, and the receptors also more in the stromal cells. So what I've discussed about the blood vessel, stromal cells, the vessel. So all these are what? They are the response of the vascular connective tissue against the inflammation in the PDR patient. We can see in the epiretinal fibroscopy membrane. So this is the correlation between the microvascular density. So now I will show you the vitreous. Now we have finished with the epiretinal membrane. Now the epiretinal membrane detachment, fibratic tissues, and their expression of soluble CD163. Now, after coming to epiretinal membrane, now we will talk about the vitreous sample. Vitreous sample. Interestingly, there is no doubt that here we have seen that when we compare the soluble CD163 and interleukin and VGF, you can see this is soluble CD163, this is interleukin and VGF. Their levels are also high in the vitreous chamber, in this jelly-like structure, which is very important for the ocular function for the ocular clarity, for the maintain the ocular structure, to build the normal pressure, for the intact of the retina. Here also in the vitreous pool, we have seen that the ELISA level revealed that the solvus CD160 into 11 VGF levels is high. Now the second testing is with that we have done with the vitreous sample by the Western blot. Here in the Western blot, you can see the level of PDR of this receptor is high. Now come to the, now I have already deal with the, we have demonstrated that in the membrane, this uh, cytokine level is high. And in the vitreous also, this cytokine level is very high. Now I'm talking about the Muller cells. Muller cell. That's why I discuss about the Muller cell and show you the picture about the Muller cell. That Muller cell is actually, people believe that the Muller cell is only responsible for the framework to build the, to put the all this structure in a proper position, but not. But the Muller cell played a huge role. It is the major source of VGF. In the Muller cell, when we treat with the cobalt chloride, which is the hypoxic condition in cell culture, we found that because of hypoxic condition, the level of this cytokine, this nasty cytokine, this bad cytokine level is increased significantly. And when we use the hypoxic inhibitor YC1 inhibitor of HIF1 alpha, it level decrease. It means that there is hypoxia. In tissue hypoxia, what we have discussed earlier, in Muller cell also we found that because of hypoxia, because this level of interleukin 11 is increased and VGF treated with the cobalt chloride, there is significant increase in the VGF also. So there is a correlation between the interleukin 11 and the VGF when the situation is the hypoxic condition. And I'm talking about the receptor. And this receptor, when we do the Western blot, we found that the level of receptor treated with the cobalt chloride is increased significantly. Now the conclusion is that, of course, because we have seen the marker CD163 M2 macrophages, so its expression is high. This marker, it means that macrophage is, no doubt that macrophage is playing the, I think we can say that it is involved in the pathogenesis of, or in the angiogenesis in PDR. This is responsible for the neovascularization, formation of new blood vessels, new capillaries, we can conclude from this. And interleukin 11, it's targeting the interleukin 11, maybe can provide the therapeutic opportunity to suppress the PDR progression. And we can see that in preclinical model of some cancer cell, they are using the antagonist interleukin 11 mutein, which is very much they are using as a therapeutic opportunity that bind with the receptor 20 times, that is more higher affinity than interleukin 11. So this is the overall about the cytokine interleukin 11 and for the macrophages, how it changed from M1 to M2, and their marker is upregulated in the epiretinal membrane, in the vitreous fluid, and in the retinal Muller cells, retinal Muller cells. Now the second title is, I'm going to discuss this article about the galactine-1 study in proliferative diabetic retinopathy. This galactine is very important molecule, because people believe that galactine-1 is the substitute of VGF. This is the substitute of VGF. That's why, when it's very interesting that if VGF, you are giving the anti-VGF, this galactine will bind with the VGF receptor and it will enhance the pro-angiogenesis. It will enhance the inflammation, it will enhance the angiogenesis. So that's why this galactine is actually glycan binding protein, the member of galactine family of beta galactosidase, and it regulates the endothelial cell function, promote angiogenesis. And you can say it is a potent pro-angiogenic property in different pathological settings. And as I told you that galactine will bind to the VGF receptor, it is a substitute of the VGF to promote the endothelial cell signaling to preserve angiogenesis for tumor. So overall hypothesis that galactine-1 is also involved in the pathology of PDR. So how interesting that this molecule is also playing a major role in the pathogenesis of PDR. So I'm not going to discuss about the PDR. I've already discussed what are the basic concepts of PDR and type of NPDR and PDR. So results are there. This is the demographic and clinical characteristic of the study subject, where we can say that males are in RDNA there are the gender, there is the age of this. So I'm not going to detail because time is very short. So here, which I can tell you that when we measure the ELISA level, ELISA, when we measure ELISA, the disease group are the PDR and RD. Actually, RD is also a, you can say, RD. People may be confused about the RD and the PDR because RD also undergo the vitrectomy. It is a rhegmatogenous retinal detachment with no PVR, and PDR is the retinal detachment, the epiretinal membrane, proliferative diabetic retinopathy. So anyway, when we see the ELISA levels, we found that the VGF is increased and the galactine was also increased. It means that they are simultaneously, they are positive correlation between the galactine and VGF. When we measure with the Spearman correlation coefficient, there are positive correlation, galactine 1 increase and VGF also increase. Here you can see that the Western blot to the vitreous sample, we analyzed the vitreous sample, we found that the galactine 1 is upregulated in the PDR. And the interesting point here we can see in the epiretinal fibrous membrane. So first of all, you can see that in the negative control, there is no expression of CD31, no blood vessels, no endothelial cells, but in inactive, there's a very less endothelial cells. CD31 is a marker of endothelial cells. I have already described this is a neovascularization, and this is activation of myofibroblasts in the PDR patient, and leukocyte infiltration is also there because it is a marker of CD45. So now the interesting point, when we talk about the inactive PDR, involuted PDR, talking about the fibrous tissues only, less endothelial cells. Active PDR, more endothelial cells, more angiogenesis, more neovascularization, and more expression of galactine-1. Huge expression of galactine-1. Stromal cells in the PDR of epiretinal fibrous membrane, when we stain with this galactine-1 in the stromal cells, we can see the more expression of galactine-1. Even here you can see the red one is the expression of stromal cell, galactine-1 is increased, but in this figure you can see there's a CD45, more leukocyte is also there. And in this F slide, you can see neuropilin. You know, neuropilin is a co-receptor of VGFR2. So this is a primary type of function. VGF bind with the VGFR2 as well as its co-receptor neuropilin-1. Even neuropilin-1 expression also increased in the epiretinal fibrous membrane. Of course. Now you can see fibrocellular membrane, the PVR. I already told that PVR is proliferative fibrocellular membrane retinopathy. That is a complication of metagenous retinal detachment. It is a complication. So here you can also see that in PVR patient, in its fibrocellular membrane, that is fibrotic tissue, fibrotic membrane, you can see there is a high expression of alpha smooth muscle actin, leukocytes, and galactine-1 as well as neuropilin-1 in this PVR patient. Even this is diabetic retina. You can see in the diabetic retina also, there's a more galactine-1 expression is high as compared to control and diabetic. I'm talking about diabetic rats, retina. Even in the epiretinal PVR patient, the levels are high. Even in the epiretinal membrane of PDR, the levels are galactine is high. Even in the diabetic rat retina, its levels are increased. Now we can talking about the microvascular endothelial cell. So actually we know that inflammation is overall process of adhesion of the molecule, migration of the molecule. So here we can see that galactine-1 is actually helping for the adhesion of the molecule. It means that if you are going to see the TNF-alpha, treating with the TNF-alpha, treating with the galactine-1, giving a shower of galactine-1, this galactine-1 level is increased, help in the adhesion. In endothelial cell, I'm talking about the retinal microvascular endothelial cell. And the same condition we are treated with the galactine-1, it is just working as the TNF-alpha. It increases the adhesion. It increases the adhesion. So it means that galactine-1 is also playing a major role in adhesion molecule. And after that, you will see the migration you know, it is very, means it's when there is a adhesion, the molecule, if anything stick with the endothelial cell, of course, the sticking endothelial cell, the process of extravasation is will migrate. So here we can see that we use the VGF. Okay, we know that VGF is actually responsible for the migration here in 0 hour, different time point. You can see at 24 hours, 0 hour, there's no change, but at the 24 hours, you can see the distance is decrease, it migration is increased. And after that, OTX, the inhibitor of galactin 1, it going to increase the migration. Here you can see this figure. VGF treatment increase the migration of protein, but galactin inhibitor decrease. It means that somewhere galactin is working with the VGF. They are, that's why there's a positive correlation with the VGF and galactin. So this is actually, you can see means very nicely the adhesion is there. Treating with the galactin, no doubt adhesion. After adhesion is the migration. You can see the proliferation of the cell. So this slide represents the force change in the migration in the human retinal microvascular endothelial cell migration. In Muller cells, because nowadays Muller cell is very important, as important than any other cell. In the Muller cell also, when we treat with the hypoxic condition or treat with the galactin, then VGF level is increased. And hydrogen peroxide, which is the oxidative stress, the level of galactin 1 is increased in the retinal Muller cells. Of course, talking about the, this is also, if you can see galactin 1 in the Muller cells, the galactin level is increased. And here, NF kappa B, we have seen that in the retinal Muller cell, treating with the OTX. Here you can see treated with the cobalt chloride in Muller cell. The inflammatory molecule, central inflammatory NF kappa B level is also increased when treated with cobalt chloride and treated with the cobalt chloride plus galactin 1 inhibitor. It means that directly or indirectly they are playing, the galactin is going to play in the role of inflammation. Conclusion. What we conclude is that the galactin 1 in the interocular microenvironment, the galactin level is high. One thing is very important. It contributes to the PDR progression and initiation. It means that targeting a galactin 1 may be a therapeutic approach for PDR therapy aside from anti-VGF because it is a substitute of galactin 1. So we need to target galactin 1 also to get more therapeutic prevention, protection. So now this is the talking about the galactin 1 interleukin 11. Now in a very brief, I am going to talk about the NADPS oxidase. This is actually, this induced oxidative damage. This induced actually oxidative stress. So here I can, there's no vitreous, no Hempel sample, only I'm talking about the retinal Muller cell and diabetic retinopathy. And NOx4 actually aposinin inhibit the NOx4. So I can tell you that in the Muller cell and diabetic retinopathy, there is a protection of aposinin. In fact, NOx4 is the main producer of ROS. It involved in the diabetic retina, pathogenesis of retinopathy. The most important that the ROX is, I'm talking about the neurotropic factor. Neurotropic factor is very important to nourish the retina, to provide the nourishment, to keep in the healthy condition. But ROS is going to suppress all these BDNF as SAT1. Therefore, NOx4 induced ROS production, which may contribute to depletion of survival factor. And aposinin, we know that this is the inhibitor, pan inhibitor of the NOx4. If we will inhibit the NOx4, then this neurotrophic factor will increase and there is a significant protection. The results are there. Because the time is very less, I will go fast. So in the diabetic retina, in the Muller cell, you can see here that in the cobalt chloride, the Muller cell, the NOx4 level is increased. And in the diabetic also NOx4 level is increased, but treating with the aposinin, the levels is decreased. Then after that, neurotropic factor, because the NOx4 is increased, I talk about the BDNF level. The BDNF level is also decreased. It is inverse because this is neurotropic factor. Because of NOx4, this neurotropic factor is decreased. The BDNF is decreased, but treating with the aposinin, and it will maintain its level. The BDNF level will be maintained. So this is the BDNF. And second, I'm talking about the SAT1. SAT1 is also neurotropic factor. So here SAT1 is also decreased because oxidative stress NOx4 increase, then neurotropic factor decrease, and treated with the aposinin, it will maintain its level. So here you can see the cascades because we are talking about the NOx4 oxidative stress that will lead to apoptosis. And here we can see the cascade level is also increased as when treated with the cobalt chloride, and when treated with the aposinin, it is going to maintain its level. So caspase 3 level is decreased, it is act as an anti-apoptotic. And here we have just seen the correlation between the ROS. So ROS level, because NOx4, ROS is the main, because NOx4 produces ROS, and reactive oxygen we measure here in the cobalt chloride, the ROS level is high, treating with aposanium, the level is decreased. So overall, this you can see the mechanism is that hypoglycemia and hypoxia leads to the increase of NOx4, increase of ROS, decrease of neurotropic factor, increase retinal damage, and after that, using the aposanium, decrease NOx4, decrease ROS4, and decrease caspase 3, and it is going to decrease early retinal damage. It means that NOx4 is the exuberant ROS production, inhibits survival factor, and caspase 3 in hypoxic Muller cells and diabetic retina. Opposite to that, we can see the deleterious effect of NOx4 derived ROS may be annulled by NOx inhibitor, decreased by NOx, inhibited by the NOx4 inhibitor, and FO is going to upregulate survival factor BD in a certain level. So it is breaking the NOx4 ROS caspase 3 circuit, APO. Thus, we conclude that the APO is a natural therapeutic agent, may minimize diabetic hypoxia, oxidative stress occurring during the early pathogenesis of. And this is my publication. And thank you for your patience. Thank you very much.